So a third project that I did in conjunction with collaborators from Georgia Institute of Technology and with the Center for Disease Control and Prevention is we looked at current implementation of screening for critical congenital heart disease. Okay? We talked earlier about how many kids can be diagnosed prenatally, but still many are missed prenatally, and many kids are born with congenital heart defects that don't realize it. If not detected promptly, there's a concern that some of these kids are going home with a very critical disease, and without getting the intervention or the treatment that they need, they could experience some pretty poor outcomes at home. So the whole idea of screening for critical congenital heart disease was recommended in 2010, became a recommended protocol for the United States in 2011, and slowly over the past 4 years has been implemented state by state, such that now it's nearly universal across the country. The issue, though, is how to do it. So we do it by doing a pulse oximetry test. You test the oxygen level in the child's hand and the child's foot, and if those levels are low or there's a big differential between them, that suggests we need to look for a heart defect as the reason for this. In different states, they're using different algorithms. You know, what's a normal level in one state is not necessarily a normal level in another. So there were no good data or studies to try to compare what how the performance is of these different algorithms. Compare, should you have a cutoff of just 97 in the foot, like Tennessee is doing, or should it be 95 in the hand and the foot, like New Jersey's doing? So it's very different. So we collected data from many places that are doing screening across the country and also internationally, and we decided, what if we just ran different algorithms on all those kids, based on their levels? What would be the different sensitivity and specificity and predictive value of the different algorithms? What we found clearly is that, if you lower your threshold for what you're going to consider a child failing screen, well, it'll raise your sensitivity. You're going to find more of the kids. But that might be at risk of specificity. You might find a lot of kids who are actually normal, all right, and they're not really having problems. That study allows us to look at differences, see how there are different algorithms, and see the different performance of the characteristics, and actually raises a lot of questions of, well, what is a false positive? Because we're doing an oxygen level test in a child, and while that kid, might not have an actual heart defect, they might have another reason for that oxygen level. So the next steps of this are going to really be looking at what's causing the false positives, what's causing certain kids to pass or fail, which type of algorithm is actually easier to use, because we've seen many mistakes in algorithms that use both the hand and the foot, which one costs less if you're using less equipment, if you only have to do one hand or the other, and then eventually try to recommend a good algorithm based on good clinical data. Well, we're not sure what's the best model. That's part of the reason for this test. I think in New Jersey they do like their model, and they had their reasons for doing it. They wanted to make sure they weren't missing any kids, and so their sensitivity was higher. Tennessee wanted to make it easier and less cumbersome to the staff, so they're catching fewer kids overall, but is it a major difference? Not really. So the question of what's best, we're not sure yet. But once we do figure out what's best, and what we think might be the next recommendation, would be to work with organizations such as American Heart Association, American Academy of Pediatrics, American College of Cardiology, who were all forerunners in the earlier guidelines. And if those three organizations, if we have some good data to support what should be done, if those three organizations were to use that data then to inform new recommendations, that would change how things are done. The biggest take home for pediatricians is to know that there are different ways of screening for these kids based on the algorithm, and that kids who fail, though, the algorithm's not perfect. All right? So, or a kid who passes the screening, and the screening says, oh, we don't detect heart disease, that kid might still have a pretty critical congenital heart disease. We're still seeing that the algorithms, none of them perform spectacularly well in terms of a screening test. So screening is just one more tool at the pediatrician's disposal to know about what's happening in the newborn nursery, but it should never replace clinical judgment.